My name is Jacob Paticki, and I'm the Director of Education and Advocacy at the University of Miami Public Health Policy Lab. On behalf of the Public Health Policy Lab and the CUGH Global Public Health Institute, we are very pleased to welcome you to this panel at the CUGH 16th Annual Conference. Today's panel brings together leading experts in epidemiology, public health policy, and clinical medicine to examine the profound and ongoing impacts of long COVID. I extend a warm welcome to our panelists, Dr. Joan Soriano, Universidad Autónoma de Madrid, Dr. Ziad Al-Ali of Washington University in St. Louis, and Dr. Esteban Ortiz Prado of the Universidad de las Américas. It is now my distinct pleasure to introduce our moderator for this session, Dr. Ana Maria Palacio. Dr. Palacio is Professor of Clinical Medicine, a clinician investigator, and epidemiologist in the Department of Public Health Sciences at the University of Miami Miller School of Medicine and the Miami Veterans Affairs Healthcare System. She also serves as Director of the University of Miami Public Health Policy Lab. Her clinical and public health research focuses on the impact of social and environmental factors, disparities in care, chronic disease management, and health policy. Dr. Palacio co-leads the Long COVID Clinic at the Miami Veterans Affairs Healthcare System, which serves patients across Florida using a multidisciplinary holistic approach. She's also building a practice-based research network of long COVID clinics in Florida to improve care models for post-viral complex chronic illnesses. Her work bridges research and policy to advance equitable healthcare solutions, ensuring that underserved populations receive comprehensive and effective medical care. I'm honored to introduce this distinguished panel, and I look forward to engaging in thought-provoking discussion. Dr. Palacio, the floor is yours.
Can you hear me? Yeah. Good morning, everyone. We know it's early, so we really appreciate your presence here. Today, as we mentioned, we have three amazing panelists who will tell us the story and show us the evidence of why long COVID is an emerging global health crisis. They'll describe to us the challenges of the definition, the physical, emotional, mental, economic impacts of this condition, and they will invite us to brainstorm together on how to put in place policies that can mitigate this condition and future post-infectious conditions that could create this type of impacts in the future. But before I introduce the panelists, let me tell you a little bit of why I'm here. As Jacob mentioned, I am a clinician investigator, and I was dedicated to health disparities until a personal experience reshaped my career. My own daughter struggled with the loneliness and the frustration of having a chronic condition like this one, called ME/CFS. And that demanded that I, as a mother and a physician, kind of like put my thinking cap and figure out how to help her, because the normal medical establishment was not helping her. So when the pandemic came along, I felt the call, and it was kind of impossible not to create a place where I could provide the care that others needed that my daughter didn't get for many, many years. So we created this COVID clinic that is growing, and today I'm here really representing them. So with that, I will introduce our first panelist, Joan Soriano, who is a medical epidemiologist at the Department of Respiratory Medicine at Hospital Universitario de la Princesa de Madrid, where he is also an honorary professor of medicine at Universidad Autónoma de Madrid and an associate professor of medicine at Universidad de las Islas Baleares in Palma de Mallorca, Spain. He has over 500 publications indexed in PubMed, more than 90,000 citations, and an Scopus H index of 102. Dr. Soriano is a leading figure in respiratory medicine and epidemiology. He has contributed to over 10 book chapters in clinical epidemiology and the treatment of respiratory and tobacco-related diseases. His contributions to the field have earned his multiple prestigious awards. Since early 2020, Dr. Soriano has dedicated much of his work to COVID-19 research. From February 2020 to July 2021, he served as a senior consultant for the COVID-19 clinical management team at the World Health Organization headquarters in Geneva, contributing to updates of WHO's COVID-19 clinical guidelines and the definition of non-COVID. He currently serves as a consultant for chronic respiratory diseases at WHO Europe in Copenhagen, Denmark. In addition to his long-standing work in asthma, COPD, and tobacco control, he continues to lead multiple research studies and clinical trials on long-COVID. So with this, I welcome Joan Toriano. Welcome to presentation.
Good morning. Thank you, Professor Palacio, and thank you all for being here on a Sunday morning to talk about this big global health problem, long COVID, and how we define new diseases. Before I start, these are my disclosures. And if we go to PubMed Central, one of the biggest repositories of medical information that we have available, we have advanced a lot in the last 5 years on the PubMed, on the pandemic. If we type, I think this doesn't work. Thank you. If we type COVID-19, we can see that in the last 5 years, there have been almost 500,000 papers on COVID-19. That you need to read about almost 250 papers per day without weekends and without sleeping to get all this information. And if you do the same exercise for long COVID, you would only need to read per day about 21 papers, again without weekends and without sleeping. So symposiums like this one today are important to summarize this type of information. For instance, last December, there was the final report of the select subcommittee on the coronavirus. This was led by Chairman Brad Wenstrup. It is a long report, 557 pages, but I strongly recommend that you read the first 2 pages with the summary on the origin of the coronavirus, the actions performed by Dr. Anthony Fauci and others, and the actions on lockdown and else. In terms of clinical updates, for instance, last December, there was this interesting clinical summary in Lancet on long COVID. We already know that 2 to 10% of the survivors of acute COVID develop symptoms that do not resolve by themselves. And you can see in here that is more frequent in those in their 40s and 50s, is more frequent in women than in men, in those with low social class or low education, and in the unemployed. In terms of risk factors for long COVID, also we know that your risk decreases if you have been correctly vaccinated or if you receive antivirals if necessary during your acute condition. So we know much more about long COVID. But from the beginning, there were denialists, people who negate what long COVID is. As an example, this is an editorial in one of the journals of Germany. The author was saying, is long COVID even real? And this was about a French paper that said that more than 200 symptoms associated with long COVID, many are self-reported, difficult to measure, and probably could be explained by other things than a new condition. So they were saying that long COVID is not real. I hope that at the end of this morning, you are correct in saying that yes, long COVID exists and it is real. This is a book that I like from an author that is one of my favorites, Gabriel García Márquez. He was the Nobel Prize awardee from Colombia, and he wrote one of his best novels, Love in the Time of Cholera. I borrowed this title for an editorial saying Love in the Time of Cholera, COVID-19 and other outbreaks. And I illustrated this with this photo. these are my nurses and young residents at Hospital de la Princesa in Madrid. They are very happy in here and posting like a football team because at the end of April 2020, they received protective equipment and even face masks to protect from the first wave. For 6 weeks, in my country, there were no face masks or protective equipment to protect yourself from the virus. And it took the best of many to tackle the first wave. But from the beginning, we already saw that many people survived the acute infection, but also these 2 to 10% were not recovering completely. There were patients with long COVID. And here you have in Nature, in October 2020, the General Secretary of the World Health Organization, Dr. Tedros Adhanom Ghebreyesus, and he was saying, we have received your SOS. We have heard loud and clear that long COVID needs recognition, guidelines, research, and ongoing patient input to shape the WHO response to this new condition. Myself, I was called in October 2020 to Geneva, and my initial target was to update the clinical guidelines on how we treat acute COVID. But when we were there, we said, there is this new condition. We need to understand post-COVID-19 condition, long COVID. And we aim in a big group to define this new condition. In the next minutes, I will tell you the outcome of a big group of people that included several WHO staff, external clinicians and scientists, but also very important, patients. One of the few good things of the pandemic is that we finally realized that we need to include patients in our research efforts and also on how we implement this research in practice. When we define diseases, we could go to the times of William Shakespeare. William Shakespeare, in his Romeo and Juliet novel, it is said that there is a dialogue in between Romeo and Juliet. Romeo is showing a rose to Juliet, and he says with a British accent, "What's in the name? That which we call a rose, but by any other name it would smell as sweet." We cannot use Shakespeare to define new conditions. For instance, in respiratory medicine, we always struggle to define even, for instance, asthma. Sol Vermont, it is quoted to say, asthma is like love. I can see from here several people that are in love, but to define how you are in love is very difficult. The same happens with asthma. Asthma, we can identify the symptoms and the signals, but we don't have a biomarker, we don't have a true clinical definition. It's only based on symptoms. That is why we need to use successful methods to define diseases, as we did in the 80s with the acquired immunodeficiency syndrome, HIV, or in the year 2000 with fibromyalgia, or very recently, just 4 years ago, with the post-intensive care unit syndrome. And the word for this is Delphi. Delphi is a geographical place in Greece. Is the Oracle of Delphi. Over there, Pythia, a priestess, was identifying the future. But we don't need to go to Greece on how we define diseases. We need to use the Delphi method. And the Delphi method is a statistical rule to identify consensus in areas when there is no consensus. In a way, you have to combine in a physical room or online all the actors that play in a problem. In this case, patients, doctors, clinicians, researchers, but also policymakers, lay people, journalist, and in a way you keep presenting evidence and you try to identify consensus according to statistics. For instance, consensus in a Likert scale is obtained when a question receives 70% or more of the responses within this 9-point Likert scale. The opposite disagreement occurs when 35% or more of the responses fall on each side. And in all other combinations of panel answers, we have partial agreement. Sometimes we need to do 2 rounds, 3 rounds or more to force this consensus. This exercise included more than 200 symptoms associated with long COVID. And eventually we identified that a definition of this new condition should have a definite or probable history of infections with the SARS-CoV-2 virus, with symptoms that present 3 months after the infection, that persist, last for more than 2 months, and very important, cannot be explained by an alternative diagnosis. After 2 rounds of the Delphi method, let me introduce to you the definition of long COVID, post-COVID-19 condition that was agreed by the panel. Includes symptoms like fatigue, shortness of breath, cognitive dysfunction. And I have to admit, it is not perfect. It is a step on the right direction. For instance, includes 96 words, and we already identified that a new definition should be explored for children. But also, very important is that after this definition, it helped us to identify core outcome sets. We need to use tests, imaging, blood tests, questionnaires to measure the treatable traits in our adult patients, and also, most recently, these core outcome sets in children, especially because we need to give answers to these patients with long COVID. I'm finishing, and I just tell you that what we need is investment. The investment in the natural history of the disease, but also in the mechanisms. At least there are 7 mechanisms identified for long COVID. I'm saying at least because likely there will be more, from inflammation at the top to maladaptation of the ACE2 receptor pathway at the bottom. But probably many of them interact synergically or in different time windows. And what we need is investment in long COVID. We need to create headlines and to be aware to the lay public and our politicians that we need this investment. And I will stop by quoting my fellow colleague and friend, Dr. Al-Ali, that will tell you later what is the burden of this condition here in the US, in the Americas, and worldwide. Probably what we need is to meet together and discuss. And these were 2 meetings that we had in 2023 in Beijing and also in 2024, where we need to globally discuss the avenues of research for this condition. So I will stop here by concluding that we have a big clinical challenge and not an easy one in front of us. That long COVID does exist, and it's like other post-viral syndromes that we can discuss later. Zika, chikungunya, hepatitis C, but the numbers are big and they are global. Finally, that we need an urgent need to quantify thresholds, durations, and timing to define it well and establish its natural history, and to help in the dialogue in between specialties and specialists. We enter the problem together. The only success is by growing together and exit the problem together. Thank you.
Thank you so much, Professor Soriano. I can say say from our experience in the non-COVID clinic that definition made a very significant difference for us because many patients were dismissed from specialists with normal tests, and the fact that this definition was broad and those time windows allowed us, it was a big tent where we could include, it was an inclusive definition where we could say, yes, you meet this criteria, you have this. And that in itself, just by telling people that they meet this criteria, that they potentially have this long-COVID condition, made a significant difference in their lives, and they felt heard. So thank you for that work. It really made a difference, not only in research, but in the lives of people, to have a diagnosis. So now what we'll do housekeeping-wise is that we'll hear the three presentations, and then we will try to devote half of the time for questions and answers and a conversation with you. So now we'll go to our second presenter, Dr. CUGH Alali. He's a physician scientist who directs the Clinical Epidemiology Center and serves as the Chief of Research and Development Service at the VA St. Louis Healthcare System. He's also a senior clinical epidemiologist at Washington University in St. Louis. He has several research interests, including pharmacoepidemiology, environmental epidemiology, global health, and most recently, short and long-term effects of COVID-19 and health outcomes. Dr. Alali led work which provided systematic characterization of the post-acute sequela of SARS-CoV-2 infection, also called long-COVID, and subsequently characterization of the increased risk of cardiovascular disease, neurological disorders, diabetes, dyslipidemia, kidney disease, and gastrointestinal disorders following the SARS-CoV-2 infection. His laboratory was the first to produce evidence characterizing the effects of vaccines on COVID, the health consequences of repeated infections with SARS-CoV-2, and the effect of antivirals on the short and long-term outcomes of the infection. Dr. Alali's lab also led seminal work in environmental epidemiology characterizing the health effects of air pollution on obesity, diabetes, kidney disease, and early mortality. His lab produced significant work on pharmacoepidemiology, particularly in comparative effectiveness and safety of antihyperglycemics and characterizing risk of commonly used medications. Dr. Alali was listed on Time 100 Health Times list of 100 individuals who most influence global health in 2024. Welcome, Dr. Alali.
Thank you very much for this introduction. Really delighted to be here. Very, very happy to be in Atlanta. It's a little cold, but really very, very happy to be at this meeting. So what I'm going to talk to you about today is a bit of a short presentation about long COVID, research, science, and policy. In terms of outlines, we're going to talk a little bit about when I think and my team thinks about long COVID, what do we think about? So what is long COVID? Talk a little bit about the burden of long COVID and its impact on different sectors. And also discuss the question that I'm sure you all should have in your thinking about, how has the risk of long COVID changed over the course of the pandemic? Briefly touch upon mechanisms of long COVID. Why does long COVID happen? What are the underlying mechanisms that explain long COVID? And then a road ahead, so looking into the future, what do we need to do in terms of policy and research priorities? So, first of all, what is long COVID? And this is really a favorite picture of mine. It's actually drawn by a kid with long COVID. She's 14 years old at the time she made this. And if you notice, that's her picture, that's a self-portrait. She's unheard and unseen. She sort of felt that she has all these symptoms, but really nobody is able to understand her. She went to doctors and they told her it's all in your brain, be more positive, go and exercise, do all of these things. All of these things would actually stick to her. So she felt really fundamentally unseen. And that really sort of was the picture of long COVID early on. And in some respects, it actually still is in many, many parts of the world. So very early on, at the very onset of the pandemic, we started hearing reports from patients telling us that they're not fully recovering from long COVID. And at that time, or they're not fully recovering from SARS-CoV-2. And at that time, actually, long COVID did not even have a name. So my team and I started asking the question, like, what is happening? Why is a viral infection that is, at the time initially we thought it was only a respiratory infection, leaving people with what appears to be really multiple problems and multiple organ systems that last for several weeks. So we asked the fundamental question, what is long COVID? And it led us to do this study to fully characterize what long COVID is using a high-dimensional approach or a hypothesis-free approach, what we'd like to say. And what we saw in people who had SARS-CoV-2 infection, long before after the acute infection has gone, these people were left with many problems, including cardiovascular disease, respiratory problem, ongoing respiratory problems, kidney problems, musculoskeletal disorders, general problems like fatigue and malaise, mental health issues, nervous system disorders. You hear a lot about brain fog, but a lot more autonomic dysfunction and other things. Metabolic consequences in terms of a new onset dyslipidemia and new onset diabetes. Lots of GI issues, ongoing constipation, diarrhea, or abdominal pain, cramps, etc. Some skin disorders, and then also the coagulation disorders. So you can appreciate that in some individuals, when they get SARS-CoV-2 infection, they don't fully recover. Most people do recover just fine, but some don't. And some end up with really significant chronic health effects in multiple organ systems. This is really a multi-systemic disorder that affects nearly every organ system. I wanted to highlight here in particular the excess burden of these organ systems. And we worry about these because these are long-term conditions that generally last a lifetime. People are having, after SARS-CoV-2, some people had increased risk and develop cardiovascular conditions or cardiovascular disorders. We see increased burden of diabetes and dyslipidemia. That's actually quite important because it also has long-term consequences. It actually itself raises the risk of heart disease and the downstream heart disease. We see also increased risk and burden of kidney disease, neurologic and mental health disorders, and gastrointestinal disorders. And that's really results in like really a significant excess burden to the point that it may really contribute significantly, we'll talk about it in a bit, to the economic burden of long COVID. So in terms of definition, I think this is really, there's been a lot of work that been done initially by the WHO and subsequently by the National Academy of Sciences, Engineering, and Medicine here in the United States to define long COVID. And I'm really glad that they sort of came to what we think is really the right conclusion, although there's a lot more work that needs to be done here. But what is long COVID according to the National Academy? It encompasses all the long-term health effects of SARS-CoV-2, all of them. And that really is really quite we think is really groundbreaking in terms of thinking about long COVID, because a lot of people sort of wanted to think about it as really only a condition that affects the brain and some other things that characterized by fatigue or post-exertional malaise and brain fog, but it's really much more than that. It's a much broader condition than that. We basically tallied up and we wanted to understand what is the global burden of long COVID. How many people in the world have been impacted by long COVID? And we came up with this number and published it in Nature Medicine about several months ago. We estimate that about 400 million people in the world, globally, who have some form of long COVID. Many of this could be also undiagnosed. And in terms of the impacts of long COVID, you'd be asking, okay, 400 million people, but how much of it really a problem this thing is? We estimate that the burden of long COVID is estimated, the economic burden of long COVID is estimated about $1 trillion per year. Just to give you an idea what $1 trillion is per year, that's really about the size of 1% of the global economic output. So the global economic output is about $100 trillion per year. Long COVID, or the economic cost of long COVID alone, is $1 trillion per year. That's 1% of the global GDP. And that's very significant. This is a drag on the global economy of 1%. This is not an insignificant problem, and we think it really needs a lot of attention. So what are the impacts of long COVID? We worry a lot about the impact on people, on individuals and their lives and their communities. But we also worry about the rise in the burden of chronic disease, and that's really important because these things cost also a lot of money. They result in reduced life expectancy. We worry a lot about kids and young adults who have long COVID, especially if they have brain fog or other neurologic manifestations. We worry about their ability to develop an educational attainment. We worry about the effect on health systems. Health systems in the United States and a lot of places in the world are already strained with rising obesity and chronic disease. And this pandemic added to that burden an additional layer of complexity and burden in terms of long COVID. We worry about labor market and productivity. People who are impacted by long COVID are not fully participating in the national economy and the global economy. And I shared the numbers, $1 trillion per year. And it's very important also to sort of think about what is sort of the pandemic globally, broadly speaking, and specifically long COVID has impacted sustainable development goals. We actually did some work on this and published it in Nature Medicine as well, to sort of characterize the effect of long COVID on different SDGs. And this is really a drag on our progress toward achieving sustainable development goals by 2030. Long COVID has impacted not only individuals and their communities, but really their social networks, support networks, and we think it has really significant social implications that will reverberate for decades. Now, has the risk of long COVID changed over the course of the pandemic? And yes, indeed it did. So we think that this is an estimate from one of our papers also recently in the New Journal of Medicine, where we showed that when you started very early on in the pandemic, 1 out of 10 people actually developed long COVID. And that has declined to about 3.5% among vaccinated individuals who got infected in the very early Omicron era. So, there's an ancestor strain initially, there's Delta, and then subsequently Omicron. And you can see significant decline in the burden of long COVID. But it's very, very important to know that even among vaccinated individuals in the Omicron era, even among that low number there, you think it's really low, but multiply that by the number of infections and reinfections that are happening in the world, there is a significant reservoir of people with long COVID, and then really the added burden of long COVID from these new infections will continue to represent a significant strain on national and global economies. So there's a mechanisms. What are the mechanisms of long COVID? It's really, at this point, there's a lot of work that's been done to try to help us understand what sort of the pathogenesis of long COVID. One of the leading hypotheses of long COVID is that of viral persistence. It's the idea that in many of us, when we get SARS-CoV-2 infection, we actually fully clear the virus. But in many individuals, they actually are not able to fully clear the virus, and they have remnant virus residing in viral reservoirs or immune privileged sites that promote chronic inflammation and subsequently, long COVID manifestations. There is the idea of immune dysregulation, either in revved up, sort of a hyperimmune response to the point that people are generating autoantibodies in the form of autoimmunity, or really a weak and dysfunctional immune response that may lead to long COVID. There is the idea of microbiome dysbiosis. We think of ourselves as humans, but the reality is that within each one of you, there are actually more bacterial cells than human cells within each one of you. And we call all of that the microbiome. And when we get sick, our microbiome also gets sick. These billions of bacteria that are actually residing within us, and their number literally outnumber human cells, they also get sick. And there is this idea that with SARS-CoV-2, they actually don't fully recover in some individuals, and that we call that microbiome dysbiosis. That leads to a state of disease. A lot has been done over the past couple years, specifically actually in the past year, to elucidate the mechanism of endothelial injury. The idea that SARS-CoV-2 attaches itself to endothelial cells, provoke endothelial inflammation. Those are the cells that line the blood vessels. They get inflamed, and then they actually promote clotting of blood vessels in the form of microclot, these small clots that can happen in the brain, can happen in the heart, in the kidneys, and you can actually deduce from this or understand how multi-organ injury can happen in the context of endothelial injury and inflammation. We talk a lot about neuronal inflammation specifically because there seems to be neurologic tropism to SARS-CoV-2, and that it affects the brain, it enters the brain, and it affects the brain, provokes neurologic inflammation or inflammation in the brain. And last but not least, mitochondrial dysfunction. These are the organelles within each human cell. Think of them as the energizer bunnies, the batteries in each human cell that power our existence. These are the batteries. These are sort of the engine of life, or the batteries of life. And then, there is this idea out there that in some individuals with SARS-CoV-2, these batteries become dysfunctional. They're not able to charge themselves. They get depleted very easily. And this is why people experience what we call post-exertional malaise. They exert themselves very, very little. They walk a block, just a block, walk the dog a block, and they end up with this profound fatigue, profound malaise after even a mild exertion. And even patients themselves, before even we discovered this idea, or this mechanism of mitochondrial dysfunction, they say, oh, my batteries are depleted, I'm running on empty. Those are sort of the words, typical words from patients with long COVID. So there is a lot to be talking about this hypothesis. Obviously, there is quite a bit of work that needs to be done to further elucidate these different mechanisms. So what do we need to do about long COVID? So what are sort of the policy roadmap? First of all, I think we need to place a whole lot more emphasis on prevention of long COVID, and that should come in the form of improving vaccine uptake, improving air quality, ventilation and air filtration systems, ineligible individuals and people really are at higher risk, in the acute phase. There is also still a role for antivirals. People with long COVID need support, and this is really important. This is really important in the US, it's important in Europe, and it's important around the world. And we really think that access, quality, and equity of care are actually quite also important, and we need to make sure that access is available, especially also in low resource setting, because a lot of people are going undiagnosed, and a lot of time are being gaslit. They're being told, it's in your brain, it's in your head, just go exercise and you'll feel better, and that's sort of as if that's sort of it's going to really, correct the endothelial inflammation, the microclotting, and the mitochondrial dysfunction, and all of these really important pathophysiology that's happening in people with long COVID. There's a lot that needs to be done for professional education and training. So I'm grateful to Anna to really have assembled this team. There needs to be more like this, really engaging people, engaging practitioners, public health professionals, and people from different professional settings, to educate them, to promote awareness and understanding of long COVID. We think that needs to happen at scale. Public health communication is very, very important. We cannot sort of disentangle long COVID from the reality that affects 400 million people around the world, and people need to know about it, policymakers need to know about it, and that really should come in the form of a really robust approach to public health communication. We think that there definitely need to be governments around the world, including the US government, must continue to support an interdisciplinary agenda for long COVID. This is very, very important. We cannot ignore this. So I talked about 400 million people around the world. In the US, we estimate that we have at least 20 million Americans suffering from long COVID. Those people need care. And the only way we can actually really move the ball forward for the American people to provide them with better support is through research. That must come in the form of coordinated approach at NIH and other agencies. There need to be a better consensus on definitions and clinical endpoints. I think we have the last time my team and I did a review to try to, internal review, we didn't publish that, to try to tally up the number of definitions. We came up with 41 definitions of long COVID. There are 41 definitions of long COVID. So I think there is no shortage of definitions out there. There is a shortage of consensus and clarity on what endpoints should be for clinical trials. Definitely global coordination. This is not a US problem, it's not an Africa problem, it's not an Australia problem, it is a global problem and requires a global approach, global coordination. This is very, very important. We cannot do it alone. We have to all cooperate together and work together to move the ball forward for the global community of long COVID. We think there is a role for professional societies for long COVID. There are professional societies for pulmonary problems, for public health, for epidemiology, for statistics, for kidney disease, for diabetes, for endocrinology. There are no professional societies for long COVID, and we think that's really, the time is overdue for this. So we're also working on this. And then really very important, the idea that we learned from this pandemic is that viruses, in some instances, lead to chronic disease. And SARS-CoV-2 is not really unique. The next pandemic is very likely to produce in its wake a wave of chronic disease. And any effort for pandemic preparedness must take into consideration this idea that viruses could also result, or acute infections can result in chronic disease. So in terms of a research roadmap, what we need to do is really further vet and flesh out the biologic mechanisms of long COVID. This is really very important because this is what's going to help us, orient, the shift towards solutions, towards therapeutics. Better understanding of the biologic underpinning of long COVID can help us really develop better treatment for long COVID. We need diagnostics, really objective diagnostics for long COVID. The field is sort of moving in that direction, in our view, a bit slowly. And it should be more vigorous and faster. We definitely need more trials, not only in the US, but globally, to test therapeutics for long COVID. We definitely understand a little bit about the epidemiologic clinical course of long COVID, but we don't understand it fully. So we need to do a whole lot more. Our group and others around the world should do a whole lot more to try to help us flesh out and more fully understand the epidemiologic clinical course of long COVID. We're providing care for long COVID. I think the Miami clinic that's led by Anna and Leo are sort of is an exemplar of like how good care can happen. But the truth is that we only have empiric evidence of what models of care are best for long COVID. And we should have empiric evidence to sort of help us understand, is a multidisciplinary clinic led by a pulmonologist or pulmonary medicine is the best? Or should it include a neurologist? Or should it include PM&R people? Or should it include a primary care physician? Or maybe a primary care physician first and then a specialty visit? So all these models of care should be evaluated to help us understand what are the models that are most effective at the lowest cost. And the model that could also potentially be scalable for low resource setting. That work needs to be done. And until it's done, we're gonna talk. I can give you my opinion, but it's really worth nothing. Empiric data are very, very, very important. You need to be asking for data. Public needs to demand data or should demand data. Opinion is cheap, data is king. And then we definitely need a whole lot more on the economic impact of long COVID. So we came up with this analysis, but I'm really glad to know that the OECD in Europe is in Brussels is actually now doing a very formal study to try to assess the global impact. Actually, among OECD countries, they can only sort of work in this within the 37 OECD countries to understand the true impact of the true economic impact of long COVID. And I think this is really very, very important to detail. And we need a lot more work on the social impact and the societal impact of long COVID. How does it impact communities? How does it impact marriages, friendships? We see people end marriages. This is all friendships. People have family strain. So how does that sort of impact our society? I think we need to understand that better from that perspective and more. So in summary, I hope to sort of convey the idea that long COVID is really a multi-systemic disease. It's a multifaceted disease that can affect nearly every organ system. The human and economic toll of long COVID is significant. This is not a small problem. This is a big problem. Risks are reduced by vaccination with antivirals, and this is a good thing. And I think we really definitely need a globally coordinated policy response and a globally coordinated research strategy. The US cannot go it alone, Europe cannot go it alone, Africa cannot go it alone. We need all to work together as a global community to really move the ball forward for the global community. Again, thankful for the invitation, and we will do Q&A after I thank us.
Thank you so much, Dr. Alari. I will hear the perspective from another region, the Latin American region. So welcome Dr. Esteban Ortiz Prado. He's a physician, scientist, and public health advocate, serving as professor and researcher at the Universidad de las Américas in Quito, Ecuador. He is the founder and director of One Health Global Research Group, which focuses on emerging and zoonotic diseases and has published over 200 peer-reviewed articles. Dr. Ortiz Prado earned his medical degree in Ecuador and then completed an NIH Master's in Medical Science in Canada, specializing in hypoxia physiology. He completed a doctorate in biomedicine from Universidad de Barcelona and was also awarded a Chevening Scholarship to pursue a Master's in Global Health at the University of Southampton. He has held key leadership roles in Ecuador's public health sector, serving as senior scientific advisor to the Minister of Higher Education and Science, and leading several research initiatives. During COVID-19 pandemic, Dr. Ortiz Prado became one of Latin America's most prolific researchers on the disease, publishing over 65 papers and serving as a trusted science communicator through television and radio. In 2024, he joined PAHO's Health Emergency Department as an international consultant contributing to global health efforts. He continues to lead and collaborate on national and internationally funded research projects with a focus on infectious diseases, health policy, and global health. Welcome, Dr. Ortiz Prado.
Thank you so much for that very kind presentation. Yes, so I will put my alarm here because I don't want you to spend the time, take more time for me to speak. So, first of all, I would like to thank for the invitation to Dr. Ana and all of the team from University of Miami. And I have to acknowledge the city of Atlanta. It's my first time here, and it's very welcoming. I have some of the highlights of the city. One of those is like the Coca-Cola Museum. It's very global, so hopefully health and access is as global as Coca-Cola eventually. So just all of the facts about the city. I have no conflict of interest. This is the index of my presentation. I won't take too much time in this because I can probably just go further, but definitely I want to make some points in terms of surviving a pandemic and surviving long COVID in a different setting. I always tell my students, if you are here already, applaud yourself because you survived a pandemic, and surviving a pandemic in Latin America is totally different than surviving a pandemic in Norway or the UK or Canada, just because we are in a different context. So I have some of the information over there. Latin America is a beautiful country. It becomes some kind of like more famous in the last decade because of artists, a lot of reggaeton everywhere. Shakira, very famous. All of these artists have put South America in the context. But also we have some negative facts. One of those is it's the most unequal region in the world. We have some of the richest people living there and some of the poorest. We have some data on poverty. You can see that poverty rates usually are above 30%. And we have, fully democracy in some countries, and in some other regions we have some, not very democratic countries. So that push a lot of people to migrate. So we have a moving population that also brings some diseases. They are walking through the continent without access to health. So with that fact, maybe you are aware of that, we are 33 countries in the region, more than 707 million people. Of course, Brazil, the most populated with more than 215 people. Mexico follow with 129, and Ecuador, where I come from, is around 18 million people. So having said that, this is one of the data that I just put there. It doesn't make actually a lot of sense to see those kind of flat curves because that's the total of cases compared to the cumulative excess date. In the left, you can see I put 75 million cases of COVID-19. Actually, the data is a little bit not clear. We estimate that it's around 85 right now million people that got COVID that we know, but I will go with some of the facts later. More than 1.8 million people have died of COVID-19, and we calculate that at least 3 million people have actually died in excess. So it was very shocking to survive COVID in Latin America. I put this data here as part of our project, and I want to go first of all with the science in the left, and then with the kind of like not science in the right. First of all, you can see in the left, that's kind of like what was the panorama for COVID-19 in March and April 2020. So we have a lot of people dying, and we have very, very little diagnosis. So in the gray, you can see people dying from COVID-19, and in the right, you can see the kind of like the purple, those are COVID cases. So at the end of 2022, we got diagnosis kind of in a good way, and of course you can see that the ratio between cases and deaths is not comparable. In the graph in the bottom, you can see the blue lanes. Those are the number of people that die in Ecuador every day. So we calculate the last 5 years before the pandemic hit, and we have something around 200 people dying every day in Ecuador. So So that's for different reasons, car accidents, homicides, and so on. So in the red curves, you can see the excess mortality during the first part of the pandemic. And of course, it was very shocking for me to be invited to the New York Times to give a talk at that time, because I was tweeting about this disease, and people were asking me what's going on in Ecuador, because in the news probably you don't remember, but people were leaving their family corpses in the streets. They were burning sometimes their own family members because there were so many people dying. So in Ecuador, so to just have an idea, in the city that Dr. Palacio comes from, in Guayaquil, usually they have 50 to 55 people dying every day during the last 5 years. But during the first week of the pandemic, they start having 700 people dying every day. So the people that burned the crops and the funerary, the cemeteries, they were just only able to burn, or what's the correct word for incineration? I think, I don't want to sound rude, but incinerate the bodies. The World Health Organization recommend that type of burning. I mean, you have to burn these bodies because we don't know this disease, and they only were able to burn 12 bodies every day. And with all of those 700 people, the first 2 to 3 days, corpses were lost. So people lost their families, they didn't know where they were, because the pandemic was so hard in Ecuador that if you have an idea, in the US, the worst day, you reported 5,000 and a little more people died for COVID in one day. That's around 1 per every 100,000 people per day. In Brazil, something around 3 per every 100,000. And in Ecuador, we have 7 people dying, so 700% more than in the US in the same day. So of course, having that influx of patients create a lot of massive problem. Now, I will go to the anti-science. We live in South America. South America is funny all the time. Politics is crazy. We sometimes have like 10 presidents in 10 years. We go to the streets, we riot a lot. And of course, politics want to become, famous with people. So a lot of bad practices went into the public. In the right top, you can see like all of these companies were trying to bring people, customers to their malls and say, hey, we have these disinfection tunnels, right? I always see these when you have cattle, they wash the people. So we have those everywhere. In the bottom, we have the major city in Ecuador, Quito. The major put a lot of effort and put money in washing the streets to avoid COVID-19. So that's what I say, like surviving COVID in Latin America is different. We traveled around the country during the first months of the pandemic, and we saw patients injecting ivermectin. If you think ivermectin is a problem in the US because some of the politics are talking about how useful could be ivermectin, we have people injecting cattle ivermectin, drinking shots of gasoline. So that's just Latin America, because a lot of people is lacking education. So surviving COVID was tough. So now we are facing, of course, the consequences of COVID. In terms of epidemiology, according to the CEPAL report and some of the global burden of disease analysis, we decreased from 2.9 to almost 5 years in life expectancy in the region. It's the region with the highest loss in life expectancy. So before the COVID, we're supposed to survive around like 79 to 80 years. Now it's around 75. So we have lost a lot of people for COVID. And this is a glance of how is one of, a very common towns, shanty towns or favelas, as maybe you might call it. This is very common even in the richest and wealthiest cities in Latin America. You can see this type of picture in, for example, in Guayaquil, and maybe 5 minutes driving, you can see one of the wealthiest neighborhoods. So a lot of inequalities, and you can see in this picture, we didn't have only COVID. We have dengue, we have Zika, we have a lot of diarrheal diseases, and we have a very weak health system in the region. So in terms of long COVID, of course, we have an issue, because we don't even know how to count how many COVID-19 cases we have. So thinking about long COVID is way more difficult. So there's around 20 studies, 21, in long COVID in the region. Some of them have described the same, symptoms, and of course, with my previous colleagues, they have a very, interesting and important summary of long COVID. I don't want to go to the detail, but some of the results are over there. We pretty much have the same reports. Women usually report more long COVID than men. According to Angarita, they say that at least almost half of the patients report long COVID. But this is also, we have to be very careful, because people who usually get into the system, the access to this type of survey, they usually are the ones that have more access to help. So there's a lot of communities that are being under, diagnosed. And we have in Latin America 500 languages, because we have thousands of indigenous communities that have no access to health. So in that term, some of the common symptoms, of course, fatigue, cognitive dysfunction, respiratory issues, and some of the risk factors are already declared there. Something that we don't know is how COVID-19 will impact our population, since we live in a region that has different, geographical difference. So I did something that it was not studied at that time. We tried to explore what is the impact of long COVID at different elevations. As maybe you know, the Andean countries of Ecuador, Peru, and Colombia, we have the highest range of elevations. And I say, like, okay, what you can do with limited resources, with not a lot of money to do research in terms of putting something, in the scientific world. So we study how elevation will impact. So anyways, we found something similar that other reports. People is complaining about fatigue, hair loss, brain fog, anxiety. So this is something that is being reported elsewhere. But there's a lot of people already in the continent that are struggling with other diseases. So this, you can see, this is a real image of Ecuadorian, the Social Security hospital. A lot of people into the hospitals trying to get an appointment, since long COVID is a public health concern for people like me that we study long COVID. But politicians and people, they are not aware that long COVID exists. So we have found that the outpatient clinics have increased in 12% after the COVID-19 pandemic. Of course, we don't know if it's because they didn't went to the hospital during the COVID-19 and now they are catching up their older diseases, or maybe these new outpatient clinics are due to long COVID effects. So in any ways, having long COVID in this population will impact our health system. We have a fragmented health system. We have people like maybe like me that I have 3 types of insurance, and there's other people that have none. So all of those people that go to the system that is universal and free, usually the system is very crowded. We have some epidemiological challenges, of course, in Latin America. One of those is, some of the definitions could be hard to implement. But for us, from Latin America, the main reason is that we have, 99 problems, as one of the singers said before. So people is not worried about long COVID, because we already have 25% of malnutrition in Ecuador. We have the highest crime rates in the world. So people is not paying attention to long COVID, and this is a fact. So we need to start doing something, because as my previous colleague said before, some of these patients go to hospitals, go to clinics, and they get these kind of like random diagnoses. You have anxiety, then you have depression, then you are just, go to the gym, trying to do something, put some effort, go and read the secret book, so you have to improve your well-being, and nobody's paying attention to the real problem. So we don't have diagnosis, and we don't have a guide that is being implemented in the region. This is something that maybe you are aware as well. If we couldn't track COVID cases, we didn't have a surveillance system that was powerful enough to find cases. How come we're going to find long COVID cases? So it's very difficult to have patients, because we don't know where they are, and this is something that we're looking for. Of course, the economical impact of long COVID, you already heard. Dr. Shahid, they select $1 trillion in the world. This is definitely important in Latin America because we are struggling with a lot of problems right now. So labor, a lot of people go into the pharmaceutical products and buy by themselves medication. We found that the pharmaceutical market also increased the proportion of people spending out-of-pocket money because insurance are not paying for a diagnosis that doesn't exist. I mean, like doctors are not using a diagnosis of long COVID, therefore the insurers are not covering, and therefore the Minister of Public Health is not buying medicine. So we have no treatment available for long COVID in Ecuador, and we have very few people that understand this, and they treat patients as well as they can, but they have a lot of limitations. So this is something, just a glance of a framework. I won't spend too much time on this, but definitely you can see that COVID and long COVID sequela are totally different in our social-cultural environment, right? Health inequalities and other problems are definitely important. I like this graph. This is something that you can see by CEPAL. They did this diagnosis of, needs that are not fulfilled versus number of excess deaths. So if you can see in the right, Ecuador, Peru, and Bolivia, we have a lot of needs that were not successfully fulfilled by the government, and that's been kind of related with the number of people dying from COVID, and therefore people getting sick or sicker due to long COVID. Definitely we need data. Sometimes when we come to this type of forum, we get very jealous in a good way because we don't have data. We don't have data available. Sometimes the only data available that we have is hospital discharge data. And you might think that someone with long COVID might not get into the hospital almost never, so you don't have the data. So it's important, it's a call for action for us to implement surveillance, getting data, and try to understand how long COVID is impacting us. Of course, we have a health system that sometimes could be very concentrated. Here in the US, you have every state will be prepared to handle a very strong hospital system. In Ecuador, sometimes you have 3, 4, or 5 cities that are the only ones that have specialists. We have, for example, cities like Entena in the Amazon jungle. There's no neurologist, and we have the highest rate of people with epilepsy due to cysticercosis, and there's no neurologist over there. So definitely we are struggling with a lot of concentration and a lack of doctors. So therefore, having long COVID, putting a lot of pressure in the already broken system, is having a great impact. We have a high demand, limited resources, and of course the absence of clinical guidance. I think I talked about this before. We don't know how to treat patients with long COVID, and sometimes they don't get the quality of treatment that they deserve. Finally, of course, the mental health burden is something very important. We have seen an increase in the outpatient consultation for anxiety and depression. We have seen a slight increase in suicide rates after the COVID-19 pandemic. And of course, we have something that is more important for me is that when you combine the data on self-prescription medicine consumption, we have seen an increase in people buying antidepressant and anxiolytic medicines in an increase from 12 to 18%. So this is something that is worrisome. We don't know exactly the cause, but I'm pretty sure long COVID has something to do with it. Then we need to implement all of the politics that were discussed before are very important to put it in place. We have very, very limited funding. The public funding for research is almost absent. It's pretty much a private effort for the universities to try to explore different things. And we have a lot of problems. So one of our main focus to be here is to try to make collaboration with people to try to help us to understand long COVID. It is a global effort, and that's how we need to understand this type of problem. So not everything is bad. We know that some health systems, especially in Brazil and Argentina, have started some sort of programs in terms of trying to find patients with long COVID, but in the rest of South America is absent. So we don't have not even a center that has specialized in treating patients with long COVID. So a lot of these people that are there have been, by themselves, no access to healthcare at all in terms of a correct diagnosis. So the public health implications and policy considerations are over there. You can see, first of all, we think that governments need to put like the official recognition that long COVID is real. We need some funding. We need to strengthen our primary healthcare. Of course, we need to, reduce long COVID in the only way that I see possible right now, that is through vaccination. Here we have an ex-minister of public health. She struggled with vaccination before. We got really good vaccination rates, and that's something that we need to put into the table. Let's keep vaccination going on. Let's keep, current and vaccines available for South America, and hopefully we can get a lot of people vaccinated. Some of the innovations that we were seeing here, first of all, we need to integrate long COVID in our health system through all of these tools that we have. Why not? We were discussing the other day that in Ecuador we have a lot of problems, and I saw this call for grants, and they are offering $50,000 to study artificial intelligence in Ecuador. And I say, maybe we should put that money in something that is actually killing us. And so here in the discussion, they say, why not using artificial intelligence to reduce the burden of diseases like long COVID? So I throw some of the ideas over there, and my conclusions are that definitely long COVID affects millions of people. We have a lot of problems in South America, and some of those are very difficult to treat, especially with a mobile migrant population. You see that Ecuadorians, Venezuela, and Colombia are coming to the US, usually walking, and all of those people have no access to healthcare at all, so they have a lot of problems, and one of those is not COVID. We need an urgent action, develop treatment protocols that are applicable for South America. Sometimes when we get these new drugs are very expensive for our settings, so we need to think about that also. Surveillance system, equitable access, and of course the government response. So thank you very much for your time. This is my lab. I just want to thank there's a lot of my young physicians colleagues that work in my lab, and of course thanking Jacob, Dr. Palacios, and my colleagues that are here in the panel to give me the opportunity to share this with such a very well-known public. So thank you so much.
Thank you. So, hope you are convinced that it exists, and that this is really a call to action. So in the interest of time, we really want to hear from you, because what we're hoping is that we're inspiring you to tackle this from whatever angle, from whatever corner of the world you come from. Maybe you can put some of that work into these many aspects that we need to know. So what I'll do is, rather than ask questions myself, I have questions, but I will ask them later. I'm really interested in seeing what are your questions. So I will open the floor for questions, and we'll go from there. Go ahead.
My name is Bob Suskind, and I want to thank the presenters today for a very stimulating discussion. And to give you a little bit of background in myself, I'm a pediatrician, and my field is starting new medical schools and medical education. But I had a personal experience with COVID back in 2020 when our family went on a cruise from Tokyo to Singapore. And that ship was ultimately quarantined because of COVID. And we came back to the US, and a number of my family came down with COVID. I went to the literature and I found out that there was a COVID-1 that had been treated successfully with Zithromax. And I decided, well, listen, I don't have anything to lose, so I put all of the family on Z-Paks. And believe it or not, their COVID responded beautifully to it. And subsequently, I'm not an infectious disease. I'm a nutritionist, gastroenterologist, but I subsequently had a number of friends and family, probably over 100 people, who developed COVID, and I placed them on Z-Paks, and we published this as a clinical observation, and they all responded to Zithromax. This is acute COVID. So I thought to myself, there were these other friends who had these symptoms on a long-term basis. They had brain fog, they had no energy, and there must have been about 4 or 5 with long, what at that time was not recognized as long COVID, and I put them on a Z-Pak. And I noticed in terms of the information that was given today that one of the theories is that it could be that these individuals have a long-term exposure to COVID that is not taken care of by the immune system or vaccination or therapeutic intervention. And these 4 or 5 people I placed on the Z-Pak. And guess what happened to their long haul syndrome? They improved. There was a contractor who had COVID, and he was knocked out by it on a long-term basis, and he responded to COVID. So I would encourage all of you to think therapeutically in terms of intervention, because I think this is obviously from your perspective, and I'm, as I said, I'm not an infectious disease, but I think one of the things that we need to look at in terms of the long haul syndrome is clinical trials using either Zithromax or Paxlovid or whatever antiviral on a long-term basis and see if patients can respond to it. Because I think this may be a clue that will be helpful in terms of the devastation that's occurring with long
Thank
haul
you.
syndrome.
Dr. Anali, do you want to comment on those, in that, on the studies that are happening?
No, I think, thank you for this. I mean, this is definitely an interesting idea. It just this is an interesting idea. It just needs to be tested empirically. I think it's an interesting idea that an antibiotic like azithromycin might be useful in treating potentially a chronic viral infection. It needs to be tested empirically on a larger scale.
Yeah. Go ahead.
Thanks for the. Do you hear me well?
Yes.
Thank you for the excellent presentation. It's actually I'm not coming from the clinical side of the physician, but I'm an epidemiologist, and I was working with COVID during that. I was with WHO and World Bank as an advisor to Minister of Health in Somalia, and I was doing the zero prevalence setting. So my question is, when we say long COVID, what duration are we talking? 1 year after the infection, 2 years, 3 years, 5 years? We have 5 years, and I understand that if you design a longitudinal cohort, it is very cumbersome. But using the surveillance data, and if you are working with the VA, you can go back to those. And apart from the IRB block, something like that, but you can do. But how? That's one question. The other question is the viral persistence in the mechanism, pathogenesis of this long term. The viral persistence, have you done any autopsy of those people who passed away when are COVID, whether these cells or even these organs, whether these organs are actually damaged, and you see those kind of inflammations that you talk? And then the other thing, we are in an era of anti-vaccine now. So what I understand, what I would like, for example, when you check people who have natural infection, how many have long COVID, and what about those who have vaccines? Have you seen any long COVID as well at the same time? And then those who have both infection and vaccination, whether they have long long COVID. Thank you.
Thank you for the questions. Yeah, go ahead.
Very interesting questions. Let me start from the beginning. Duration. Duration is what we were thinking that the symptoms occur from 3 months from the acute infection and last for at least 2 months. Connected with the first question regarding children, for instance, this is something that the treatment with antivirals should be in those with viral persistence. So you cannot, in the long term, after, for instance, in the longest cohort that we have of patients comes from Wuhan. Dr. Bing Cao in Wuhan has already published 4 years of data, and the prevalence of long COVID symptoms decreases year by year, but they do not vanish. And that's the thing that we are seeing in most cohorts, that in some individuals, of course, with aging, there are symptoms, but the individuals with long COVID decrease with time, but they do not vanish. And important with children is the problem that we see this in Europe. There are mothers and fathers whose children cannot play video games. It's not that they cannot do sports in school. It's that for 4 years they have brain fog when studying or when playing video games. Of course, this is something that is very bad for the entire family, for the brothers and sisters. The last question that you had is again is on vaccines. And again, the anti-vaccine problem is very important. There are people ready to accept anything that you will see on TikTok, on Instagram, and other. And the lobby of anti-vaccines is still very healthy in 2025. Again, what we need to do is education and be persistent that vaccines and COVID vaccines save lives.
I think the part of the vaccine, to elaborate a little more, I think Dr. Ali showed that slide where after the vaccine, the incidence or the prevalence of long COVID is smaller, but it's still very significant. I think Dr. Ali, you said like 3% or 3.5%?
Yeah,
3.5%. So yes, so the vaccine does help, but it doesn't eliminate the problem. So, but for sure, it reduced it like from 10% to 3.5%. So vaccination is one effective strategy, even though it's not absolute. But very important to keep that in mind, especially in this time that we're hearing that maybe the COVID vaccine will be, I don't know, not encouraged or worse. So we need to keep that in mind. Yeah, go ahead.
Thank you. I really appreciate these talks. My name is Carrie Grossarts-Deuce, and I am from a small college, Ithaca College in New York. I study zoonotic and infectious diseases and antibiotic resistance and microbiome studies in wild primates. So it's very interesting to me, specifically in Costa Rica. And I was seeing that gut dysbiosis was one of the potential causes. Do you have any data on what the profile looks like of what microbes they are, and like what is it more singular profile of different microbes? I actually have a couple of questions related to that. And were there any studies done about treating individuals with pre and probiotics, and was there any improvement? And then finally, I was interested of your CPAC question. Was it effective? Maybe it's potentially a question to look at pre and post CPAC gut microbiomes and to see what has shifted.
Yeah, no, thank you for this. So there have been some studies documenting a drift in the microbiome or changes in the microbiome following SARS-CoV-2 infection, and sort of different profiles in people with long COVID. So that's sort of really an evolving field. There is one trial, one RCT actually, randomized controlled trial that came out of Hong Kong, actually showing that a probiotic, and has a specific name for that actually ameliorated or improved symptoms of long COVID. That was actually an RCT published in the Lancet Infectious Diseases about 18 months ago. So there is evidence, from randomized evidence, but you know with microbiome, there's a lot of, it differs dramatically by diet and geography. So what works in Singapore, what works in Taiwan, what works in Hong Kong, and this RCT came from Hong Kong, from a very nice group in Hong Kong, may not necessarily work in California or on the East Coast, right? Because the different geographies have actually significantly different microbiome, and it changes dramatically by diet and a lot of other considerations. And I think one of the things that also came to my mind when he mentioned or invoked the idea of CPI is whether this is actually causing change in the microbiome or somehow pushing the microbiome to restore itself, right? I mean, the idea that, with SARS-CoV-2 infection, there's microbiome dysbiosis. Antibiotics obviously, significantly challenge the microbiome, right? And maybe regenerate or their application after exposure to antibiotic sort of restores it back or resets it. It's kind of like a reset, when you sort of blast it with, Z-Pack is a very powerful antibiotic. So it's sort of a blasting these bacteria. So it's really unclear though. This is also a speculation. I think a lot more needs to be done in this space to sort of further elucidate the role of microbiome, whether actually probiotics really help. That RCT is only a singular RCT. It's only one in the world coming from Hong Kong. Again, it's very, very hard for us to sort of accept it in the US. But we have different microbiome. That's the reality. Right? And our people here may not necessarily respond to the same therapeutic. There's a lot more need to be done in this space to sort of help us evaluate the role of microbiome in the biology of long COVID.
Thank you. Also, I just remember that we didn't answer the question of the persistence, and there are autopsy studies. So they have done autopsies, and they have found the virus in different tissues, not only the lungs, but brain and other tissues. So there is evidence that the virus is there. In fact, in our clinic, we were doing skin biopsies to check for small fiber neuropathy and check for this endothelial dysfunction in the capillaries, and we found one of the biopsies had the virus in the biopsy. So there is persistent, and that is why things of what could. There is a study going on Paxlovid, an antiviral that is run by the NIH, trying to see if eliminating the viruses, this persistent helps. One last thing I'll say before we go things is the earlier, and this is anecdotal, I'm going to say there is no evidence on this, but we do have over 1,500 patients, and the earlier that you do something, the more chances that you have to make a difference. So early diagnosis helps. If somebody has been struggling for 2 years, it's like a house of cards has come down, and a lot of systems are offline. The hormones, the microbiome, a lot of things are abnormal. So one intervention is less likely to help. If you pick up somebody, the patients that we pick up early, and we started doing things early, were they had faster responses. So that's something important, because we need to not only diagnose, but diagnose as early as possible to try to return them to homeostasis. Okay, go.
Leo Tamariz from the University of Miami, Dr. Ali. You appeared before Congress, and I remember vividly seeing it on TV with my colleagues. And you said, on your opening statement, you said there are no FDA-approved treatments for COVID. And that continues, unfortunately, to be the case. How can we move faster?
Well, thank you for this. I think that definitely more resources and really more streamlining the resources toward randomized controlled trials. I think what has happened is that some of the resources that were given to NIH were spent a lot on epidemiologic data. Well, that could be could be actually done much more cheaply and faster at the VA and Kaiser and Sutter and other places. I think there need to be, at the level of NIH, a whole lot more concerted effort of channeling resources toward RCTs, and that also requires really a global coordination. The U.S. should not and cannot go it alone. There is a role for European nations and other places to also invest resources in RCTs. And I think we need to also facilitate entry of the pharmaceutical industry into the RCT space. One of the challenges when we talk to, let's say, the chief science officer of Pfizer, and occasionally I get with him on calls to sort of talk about the science of long COVID. One of the challenges that we're not going to go into this because of the really lack of clarity about clinical endpoints of long COVID. So if they wanted to invest X amount of dollars in a trial, who would they enroll? What type of endpoints should they be looking at? What type of endpoints would also be acceptable to regulators like the FDA? All of that should be fleshed out to really help facilitate entries into clinical trial. Until we do this, we're not going to have a massive clinical trials from the pharmaceutical industry into COVID. They've been reluctant. Pfizer have been reluctant. Other pharmas have been reluctant. And we see small trials here and there, but you don't see a very focused effort or large-scale effort by really the behemoths or the giants in pharma toward long COVID. And when I investigated, you guys have all the resources. Like, why don't you do this? And they mentioned this. There's a lack of a consensus on definitions and clinical endpoints. And if they envision an endpoint, would that be acceptable to regulators? I think those discussions need to be had. That consensus needs to be built to help facilitate this. And on the government side, there need to be more focus on clinical trials. I think, and I'm delighted that in the past year, sort of recover the major NIH initiative that has been, focusing on long COVID seems to have, corrected course and then devoted attention to what they call now recover, treat long COVID, the recover TIC. So that's really the initiative that was launched in September of 2024 by the NIH. Called the Recover TIC. So rebranding of the original Recover, really focusing toward TIC, Treat Long COVID. And I certainly hope that sort of that gains momentum and we keep keep moving it forward to really have more trials, evaluating different therapeutics for different endpoints in long COVID.
And Anna, if I can add to this response, if you don't have US approved therapies, in Europe we do have approved therapies for long COVID. We have antivirals, we have biologicals, and we have metformin. Metformin is something that is diabetes drug that is just 2 cents a day, and there is evidence from clinical trials well performed that it reduces the incidence and the severity of long COVID symptoms. So this is something that actually we are giving to our patients actively, apart from other things. Before it was mentioned, the microbiome, probably probiotics will help. We are doing clinical trials on traditional Chinese medicine. The Chinese for 4 years already, they are using their medicine with very good results. The problem is that they publish their results in local journals, but we need to learn from them because they are getting extraordinary results. So the thing is that we need to continuously update the guidelines with the new evidence and produce this research in our patients.
Thank you again for all of your comments. Two questions. One is, have you seen very many patients who have not had documented COVID with long haul syndrome? And secondly, have any of you seen any patients presenting with tinnitus and long haul syndrome?
Two very key questions, and the answer to the first one is yes. In global health, this is a meeting on global health, there is a mantra, leave no one behind. For instance, in the first definition of long COVID, we said definitive or suspected acute infection, especially because in the first wave, there were no diagnostic tests. So the answer is yes. We see individuals that they do not have a definitive infection, but they have symptoms. Of course, we need to disentangle which is what, because there is always cause and effect. But the answer is yes. And tinnitus, the problems with the ears, again, is something that for the ones that we do not suffer it, we could consider banal. If you have this problem, it's extremely energy consuming and limits your daily life. If you are listening continuously, beep, 6, 10 10, 12 hours a day in your ears, you can do nothing. Tinnitus is something that damages and limits the health of long COVID patients. And in the Lancet Commission of 2 months ago, they said that even people with tinnitus have more dementia. So tinnitus is a key symptom in long COVID.
But has it been associated with long haul syndrome?
Yes, yes.
It has.
We do, I mean, long COVID has been associated like with over 200 symptoms. Again, I'm going to speak as a clinician anecdotally now. We do see a lot of tinnitus in our clinic. And when I was searching for how to help, because it is disability, it's incredibly burdensome. So I was searching the literature and I found a connection with salicylate intolerance and microbiome alterations creating salicylate intolerance. So I said, what do I have to lose? I put the patients on low salicylate diets and they improved. So again, it's anecdotally, but we're trying to figure out how to help people. Yeah.
Janice Bach, pediatrician from SUNY Upstate Medical University in Syracuse, New York. Thank you so much for all this wonderful information. 2 questions. One, as you said, the 200 symptoms, I hate to ask specifics, but do you have experience with trigeminal neuralgia as a long COVID symptom? And thoughts on people with long COVID and reticence to continue to get the vaccine after they've experienced long COVID? Thank you.
Anyone who wants to take the first one?
Well, trigeminal neurosis is usually associated with zoster. And again, the causality in medicine is something that sometimes is physical, but sometimes is statistical. So there is always the cause and effect, the before and after. I'm sure that there will be individuals that their main problem after COVID will be trigeminal pain neuropathy. To establish causality is a different thing. And the thing that you mentioned on revaccination and vaccine booths is something very important. Mothers and fathers, sometimes they are reluctant to revaccinate their children. What we know with, again, very solid evidence is that every year that you are vaccinated, you reduce the chances of acute infection, but also you reduce the chances of long-standing symptoms, long-standing symptoms compatible with long COVID. So the public health message is that we need to fight the anti-vaccine.
Yeah, and to answer, in our experience in the clinic, we do see a lot of fear that the symptoms are going to be worse. So we try to inform them and allow them to make the decision themselves. So we tell them, we show them the evidence that Dr. Adali showed us, that the risk of getting it is diminished, that maybe the symptoms get diminished. There is already studies done by patient-led coalitions that have asked these questions to thousands of people, and they report that kind of 30% get better after a vaccine, 30% do not change, and the 30% could get worse temporarily. So there are that. Obviously, it's not super scientific. It's kind of this patient-led surveys that are led to social media from patient coalitions. So we present this data, and what we do, to tell you some practical issues, is that we premeditate. So when we give them 2 days of steroids and antihistamines, so the day before, the day off, so to try to mitigate, and we have seen that still they get the response, immunological response to the vaccine, but this a big response that some of say that they were like in bed for a week, that is mitigated with premedication. Yes?
I am Quating from the Daley Institute for Global Health Research in Toronto, Canada. So Dr. Soriano, in your presentation, you talked about how there needs to be improved preparedness and global coordination for COVID. So I wanted to know your thoughts on the pandemic treaty that the WHO is developing and its potential implications for long COVID.
How long time do we have? Because this is a key question. Preparedness is something that now the question is not what will be the next pandemic, but when. And again, if we are thinking of trillions of dollars have 12 zeros. And for instance, the estimate of what it would need to have an army of nurses, practitioners, and epidemiologists ready for the next pandemic, it has been estimated as $1 billion. So it's 1 per thousand of the estimated excess in a single year. So the thing is that, of course, we are living difficult times. But I will not say names, I'll try to be elegant, but these are times of uncertainty. To convene $1 billion is something that myself, in my pocket today, I don't have. But even the world leaders could commit for this, especially because it's an investment not to have the estimated. I'm not only talking about cost, I'm talking about millions of lives and sufferers later on. So this pandemic response from WHO is something that I vote for that. There are many people working, and probably we can change some opinions in the next months and years.
We're running out of time. I think we ran out of time. But really,
One last question. Have any of you seen any patients who have had long haul syndrome after being vaccinated but not having had the disease?
So what was that? Can you repeat that, please, the question?
Have any of you seen patients who've not had the disease documented, but who develop symptoms of long haul syndrome after vaccination, or with the vaccination?
I mean, we found some, in our study in Ecuador, we found that definitely people who got COVID-19 before vaccination have more symptoms than when they got COVID after vaccination. Now, in Ecuador, for example, at the beginning of the pandemic, we have 1 documented case per every 100 deaths. So a lot of people at the beginning got COVID with no diagnosis. So I'm sure here, because of the arrival of the vaccines, measuring IgM, it will be probably useless. They will probably have some data in the BA system that might answer that question.
Anecdotally in the US, thank you for this. Anecdotally in the US, several patients actually reported having sort of symptoms that resemble long COVID after being vaccinated. There's just recently, just literally 2 days ago, a preprint came out of it was at lab and David Vetterino. They put it out in preprint. This is not being peer reviewed. Very, very, very small study. Where they actually documented that some people after exposure to the vaccine, or actually after being vaccinated, also develop some sort of a form of vaccine injury, the phenotype of which resembles the features of long COVID. So I think we're beginning to understand more about vaccine injury. I mean, I think vaccines are safe, generally safe, but I don't think anyone would say like any drug in the world is 100% safe, right? And so that preprint is really interesting, but again, it's a preprint, it's a very, very, very small study, but from a very, very respected immunologist.
yeah,
That's a very quick comment question for Dr. Ortiz. The advocacy groups in the US or patients who have long COVID get together and they're pretty powerful here. I don't know if in Latin America, are they organized? I don't know if in Europe they're organized as they are here. They actually have been really powerful in moving the recovery issue. So I want to start with Latin America and Europe, hopefully.
In Latin America, for long COVID, definitely there's no patient groups that I'm aware of. I know that some patients in Latin America, they are very reactive instead of proactive. I mean, like if they get lack of treatment, then they will go to the media and the streets, and they become a little more powerful than before. But in long COVID, as I'm aware, there's no groups of patients yet. So,
very briefly, in Europe, the patient advocates and the patient associations with long COVID are becoming extremely useful. I mentioned before that if we can think of one positive one positive of the pandemic, this is the patient involvement. In grant applications, it's compulsory. It's not only invited, it's compulsory to have patients involved in the research team because they tell you, hey, these symptoms, these outcome sets, this is something that bothers me or my family. So the involvement of patients that also some of them, they actually are engineers, they are lay people that they are very good and add up to the research team. So if only the funding of the patient associations is something that also should be encouraged worldwide.
Completely agree. So thank you so much. We hope that this inspired you, that you hear our call to action, that wherever you are, there is so much work to be done. You have passionate people that are willing and ready to collaborate with you. So hopefully we can do things together. Thank you for coming.